Dr. Patwari?
Yeah.
I have the patient in room 23. I wanted to give you a presentation.
Oh, okay. Yeah, go ahead.
So I have this 58-year-old man. He's got a history of hypertension, hypercholesterolemia, coronary artery disease with a prior MI and stent.
Okay.
He's coming in today with chest pain. So the pain started 3 days ago when he was walking from the grocery store.
Mm-hmm.
He said he developed an intermittent substernal 7 out of 10 chest pressure that's worse with exertion, better with rest, and better with nitroglycerin as well.
All right.
So the pain, again, intermittent, lasting about 20 minutes per episode, and he noted some radiation to the left shoulder. And the last episode of this chest pain was just right before he came here today.
Okay.
So the pain is associated with shortness of breath, nausea, and diaphoresis, but he denied vomiting, fevers, chills, cough, and no recent trauma or prolonged immobilization or leg swelling. So again, this patient has a history of hypertension, high cholesterol, coronary artery disease with a prior MI and stent. He's got a father with a heart attack in his 50s, and he's a smoker, so those would be his risk factors.
All right.
But he denied any drug use.
Okay.
And then for that prior MI, he does say that this pain is similar. So again, to review his past medical history, he has high blood pressure, high cholesterol, coronary artery disease with the MI and the stent. He was hospitalized for cellulitis in 2001. He's got eczema, blepharitis, gout in his left foot in 1999. For surgeries, he had a knee replacement 3 weeks ago, his left knee. He had an appendectomy in 1990.
Mm-hmm.
Social history, he drinks 5 to 7 beers on the weekends.
Okay.
But he answered 0 to all the cage questions.
All
He's
right.
a 30-packer smoker. Again, no drugs. Family history was pertinent for MI in his father in his 50s. His medications include lisinopril, metoprolol, aspirin, Plavix, nitroglycerin, and simvastatin. He's allergic to penicillin.
Mm-hmm.
So for review of systems, everything was negative except for nocturia, blurry vision, and left knee pain following that recent knee replacement.
Okay.
On exam, his blood pressure is 130/80, heart rate of 108, respiratory rate 12, temperature 98.6, and his pulse ox is 98% on room air. So this is a overweight gentleman. He's in kind of mild discomfort, but he's oriented and he's mentating clearly.
All right.
HEENT. His head is normal, cephalic, atraumatic. He had anticteric sclera, pink conjunctiva, no nasal discharge, moist mucous membranes, no pharyngeal erythema, edema, or exudates. His neck was supple, no bruits, no JVD. Cardiovascular exam, his chest wall was non-tender. He was tachycardic with a regular rhythm,
Mm-hmm.
normal S1, S2, no S3 or no S4, no murmurs, rubs, or gallops, no pedal edema, and then his pulses were +2 in the bilateral radial and dorsalis pedis areas.
Okay.
On lung exam, he was cleared auscultation, no wheezing or crackles, but I did notice some slight increased work of breathing, but he was able to speak in full sentences, no accessory muscle use, and no retractions.
Mm-hmm.
Abdomen was non-distended. He had normal bowel sounds, soft, no tenderness, no organomegaly. On MSK, his left knee had some mild tenderness without edema or effusion, and no other MSK tenderness noted. His skin's warm and dry, no rashes. Again, he was alert and oriented ×3, and then he was had a pleasant and calm mood. His results were significant for the initial EKG showing sinus tachycardia, but there were no ST segment changes.
Mm-hmm.
Troponin was 0.03, and then his chest x-ray showed no acute cardiopulmonary process, and he had a CBC and BNP that were normal.
Okay.
So for my assessment, this is a 58-year-old gentleman, again, past medical history of hypertension, high cholesterol, coronary artery disease with a prior MI and stent, coming in today for chest pain. On exam, he's obese, he's tachycardic with otherwise normal vital signs, clear lungs with some increased work of breathing, but no JVD, no pedal edema. So my assessment of his chest pain is that he most likely has acute coronary syndrome. The evidence for this would be that he has some typical chest pain for ACS, and that it's pressure-like,
Right.
exertional, associated with the diaphoresis, the nausea, the shortness of breath. And then again, he has multiple CAD risk factors, hypertension, high cholesterol, age, the prior MI, the prior stents, tobacco use, and the family history. Other things on my differential would be PE, pneumonia, pneumothorax.
Yeah.
So for PE, he does have a risk. He had this recent surgery 3 weeks ago.
Right.
He's tachycardic, and then we noted that increased
Yeah.
workup breathing.
Right.
But he wasn't saying it was pleuritic. He didn't have any hypoxia, and he didn't have any calf edema really.
Mm-hmm.
So for the pneumonia, again, the chest pain, shortness of breath would make him at risk for pneumonia, but he didn't have a cough or a fever, his lungs were clear, and his chest x-ray was normal, so probably not.
Okay.
And then for the pneumothorax, again, the evidence for that would be that he, again, had the chest pain, the shortness of breath, but he had no risk factors for pneumothorax, and his lungs, again, were clear with a normal chest x-ray.
Yeah, right.
Okay, so for my plan, I want to repeat that EKG and the troponin in 4
Sure.
hours. And then if those were normal or unchanged, I'd like to get a nuclear medicine stress test.
Okay.
Okay, and then a D-dimer because I want to check for PE.
All right.
And then let's give him aspirin.
Mm-hmm.
And then we can maybe order nitroglycerin or morphine if he's got pain again. So then for that EKG and repeat troponin, I think if there's any changes that would suggest ischemia, we should consult cardiology. Same if if the stress test comes back abnormal, I would call
Right.
cardiology and suggest a coronary angiogram with a PCI. So for patient education, I think he should be educated on heart-healthy diet with a nutrition consult, and also
Yes.
be encouraged to lose weight,
Right,
maybe get an
right.
exercise regimen for him once he's feeling better. And then for disposition, I think let's observe him on the general medical floor with cardiac monitoring.
Great. That was a wonderful presentation.
Thank you so much.